Hi, my name is Tara Igoreta, and I will be doing a presentation on a patient that I met that I will call Lenny. First, to let you know a little bit about myself, I am in my first clinical rotation in the FNP program at Bradley, and my first rotation was in a HEMA clinic at the University of Chicago, a very busy clinic and very fast paced. And I did learn a lot there because it is a teaching hospital and they're doing lots of research projects and things like that there. The patient population that I primarily worked with was myeloma, lymphoma, and mostly stem cell transplant patients. So we did not do a lot of diagnosing of patients there, but more or less follow-up visits and maintenance of their diseases. These patients are usually seen about 2 to 3 times a week. So you kind of get to know the patients and, make subtle changes on their plan of care. And then also I went to clinic on Fridays a lot, which they have a clinic called Top Clinic on Fridays, which is a multidisciplinary clinic that sees patients that are potential transplant patients. So the objectives of my project were for you to define myelofibrosis, diagnosis and the best treatment options for the disease, understand how to assess patients' vulnerabilities before stem cell transplant and how our findings may affect our care plan, define what the purpose of the Top Clinic is and how it can help potential stem cell transplant patients. So now we can meet our patient. His name is Lenny. He is a 61-year-old male. He was diagnosed with myelofibrosis in December of 2016. Currently is being treated with ruxolitinib, also known as Jakafi. At his visit today, he's here at the Top Clinic for an eligibility assessment for consideration of an allogenic stem cell transplant. So I was not present on his initial diagnosis of myelofibrosis, but I do kind of want to go over what myelofibrosis is and how you would come to a diagnosis of myelofibrosis in a patient. Myelofibrosis is a blood cancer. So the blood cells in the bone marrow become abnormal. And they cause scarring of the tissue or fibrosis and chronic inflammation. The blood production eventually will move to the spleen and it causes splenomegaly, which is a classic sign of myelofibrosis. We have discovered that there are mutations in the genes that may lead us to a diagnosis of myelofibrosis. So they're not inherited in our DNA, but they are changes that occur over time in our lives, and they affect the proteins in the cells. The mutations that are commonly seen in myelofibrosis are JAK2, which is seen in 50 to 60% of the patients, and CALR mutation, which is found in about 23.5% of the patients. The symptoms and signs and things that will lead us to a diagnosis of myelofibrosis. The patient will come in with findings, complaints of being tired, having some shortness of breath on exertion, may complain of some left upper quadrant pain, that is where your spleen is, may have some signs of fever, night sweats, weight loss, bone pain, bleeding, and easy bruising. A lot of these signs or symptoms we kind of see in a lot of cancer patients, but we can't determine exactly what type of cancer until we do further testing. Other risk factors that you might want to ask about to patients is any exposure to chemicals. Petrochemicals like benzene or toluene are usually seen in industrial areas, gasoline type products that can be hazardous and a risk factor for cancer. Signs that you may see on exam, you may see an enlarged spleen. It's not always the case. Sometimes you won't notice that until you do an ultrasound, but also like pale mucosas. The patient may be anemic when they come in. Loss of muscle mass. They may have some weight loss from their previous visit, some muscular atrophy, weakness, and fatigue. So it's hard to determine an actual diagnosis until further testing is done, but some specific differential diagnoses for myelofibrosis would be other cancers such as chronic myelogenous leukemia, hairy cell leukemia, essential thrombocytosis, myelodysplastic syndrome, and histoplasmosis. And then to do further testing to see what our diagnosis is, we would look at our physical exam and our history. We would also get a CBC with DIF, which will most likely show us some leukocytosis, maybe thrombocytopenia, possible anemia in the patient, and we may see blast in the differential, which is usually indicative of cancer. Then we would move on to a bone marrow biopsy. We get a sample of the marrow, look at the cells and see what kind of cells are forming. And then the gene mutation analysis will give us an idea if we have any of the mutations that are common in this type of cancer that can help lead us to the diagnosis. So for our patient Lenny, his initial presentation was that he was a 60-year-old male with a health history of interstitial lung disease, pneumonia, post-inflammatory pulmonary fibrosis, steroid-induced diabetes, sleep apnea, and chronic leg pain. He had no previous surgeries. And then for his social history, he did confirm that he had occupational exposure to steel, auto, and tire industry, working as an electrical engineer. Also living on a small farm, he had frequent exposure to birds, farm animals, molds, and sawdust. And he was a cigarette smoker of 2 packs a day for 24 years. In his family history, we've noted that his father had liver disease, cardiovascular disease, and liver cancer. And then his paternal grandfather did have a cancer of an unknown source that he could not describe. The symptoms that he came in with included 2 weeks of fatigue, weight loss of 10 pounds. He reported night sweats, bilateral leg pain, but he said it was different than his normal chronic leg pain and it felt like it was in his bones. On exam, signs included patient fatigue, weight loss demonstrated by records and current weight. He had some upper extremity strength loss, and splenomegaly on exam. So they went ahead and did further testing. His CBC did show a leukocytosis with blasts that were present. And then his bone marrow and his gene mutation analysis confirmed diagnosis of myelofibrosis. The patient was JAK2 mutation, and he did have another mutation called IDH2, which is usually gives the patient a poor prognosis. So the treatment at this time, he was then referred to the HEMA clinic, and the patient was started on rituximab, Jakafi chemotherapy regimen. That is the typical treatment for these patients. And he was on this therapy for about 6 months with some improvements in his blood counts. His spleen did have some shrinking, and he had a modest improvement in fatigue. However, blasts were still present in his differential. And so we decided to start evaluating him for further care. So on my visit, he came in to be evaluated for a stem cell transplant because stem cell transplant is actually the only known curative therapy for myelofibrosis. So let's just talk quickly about stem cell transplant. An allogeneic stem cell transplant involves transferring the stem cells from a healthy person, who is your donor, to an affected person, like Lenny, after high-intensity chemotherapy or radiation. So it is a high-risk procedure because of the intensity of the conditioning regimen prior to transplant, which is required to impair the patient's ability to make their own stem cells. We basically are wiping out their stem cells to give them new stem cells to fight the disease. The goal of the therapy is to activate the immune system to reduce the chance of stem cell graft rejection. It enables the donor cells to travel to the marrow, and that's called engraftment, and produce blood cells. And that creates a graft versus tumor effect, in which the new cells take over and the tumor cells go away, or bad cells. There are major risks with this procedure. The patient will be immunocompromised, so they are at high risk for other infections. And then they are very high risk for graft versus host disease, which is when your host cells do not see the graft cells as their own and reject them. So you will see a lot of rashes. You'll see the mucosal lining of the GI tract will be damaged at times, so you may see some sores in the mouth. You may see nausea, vomiting, diarrhea, abdominal pain type symptoms. And then, of course, our older adult population is always at higher risk. So what is the TOP Clinic? TOP Clinic stands for Transplant Optimization Program for Older Adults. It is basically a clinic that it's an interdisciplinary team that includes physicians. Physicians include infectious disease, geriatric, and stem cell. And then you have an advanced practice nurse, which is who I was working with, and then a physical therapist, dietitian, social worker, and clinical research coordinator. The program was established in 2013 at the University of Chicago. It was committed to optimizing patients' health and improve success rates of transplants in older patient adults. So why was Lenny chosen to go to this TOP Clinic? Well, Lenny is a 61-year-old male and is therefore considered an older adult. And Lenny has some comorbidities, including interstitial lung disease, that has caused him previous hospitalizations in the past, and at one point required him to have HOMO2. So he is a high-risk patient for transplant. All of the assessments and testing done at the visit help us to determine if he is a good candidate for stem cell transplant and what we can do to optimize or increase his chances of survival after a transplant. So some of the things that we look at the visit, we look at his physical function. We ask questions about AIDLs, if he's able to not only do his normal daily routine and take care of himself, but also do things like take care of his meds, take care of bills, and things like that. We ask about if they've had frequent falls, because that can put them at higher risk. We do tests like the time up and go, a 4-meter walk, and a grip strength test, all giving us idea of their physical function and strength. We look at their nutrition. We look if they've had a lot of weight loss, if their albumin is good. He's usually a good indicator of nutrition. And we ask about their diet. Then we look at their comorbidities, which we use a scale called this HCT-CL. And it gives us a score and tells us, what our mortality and morbidity rates maybe for going through with transplant. So we look closely at the H&P, we look at their nutrition, we read about any consults that they may have had in the past. Then we also look at labs, including the bilirubin, serum creatinine, and LFTs to look at their the function of their organs. We do a pulmonary function test and an echocardiogram. And that will all give us a number for the comorbidity score. And then cognition, we do some neurocognitive testing, and we like to ask about delirium, if they've ever had delirium or dementia, or if they've had it within a hospital stay, which can be can cause problems with the care in the hospital. And then we look at social support. Do they have a support family and friends that can support them through transplant? Are they social and active now, or do they have limitations to their lifestyles? And then we also look at psychosocial status or psychological status to see if they have any signs of depression or anxiety, which is very common in these cancer patients. And then we also focus on polypharmacy, so we take a really good look at their medications that they're currently taking, see if anything will need to be stopped during transplant, or if we need to do dose adjustments on medications that they may need to take due to renal function. And then just to get an idea of how successful this clinic has been, looking at the scores over a 4-year period, you can see the scores the 4 years prior to starting the top clinic and the 4 years after top clinic had been started. And the scores are significantly higher in survival for the patients that went through top clinic. You go through from 69.8% at 100-day survival to 90.7% at 100-day survival. And still the same with the 1-year survival is also better after for patients that had been involved in top clinic. So let's talk a little bit about Lenny and his visit and what we found. So for his comorbidity score, he was scored a 4, which is pretty high. His pulmonary interstitial lung disease gave him a score. He had elevated LFTs, which also scored him, and depression. The most problematic area for him is the pulmonary condition. However, we did do repeat PFTs, which had been better than his previous. And then his ejection fraction was 65, which they like it above 50, so that was fine. And then for functional status, he only did 400 meters for a 6-minute walk, and the goal for his age would be 521 to 623. So he was below the average, and he reported 5 of 10 fatigue after completing that test. And then they did a score for grip strength, which was 36, and a 0.96 second 4-meter walk, which does not indicate him as frail. Fragility often is a sign that patients will not do well with transplant and have higher mortality rates. He described having few falls in the past 6 months due to his neuropathy, but overall had good strength. In his AIDLs, stated he was able to take and pay his own bills, manage his own medications, and complete household chores, so there were no limitations there. And then for emotional health, he did state that he both had anxiety and depression, and is currently taking antidepressants. Also, for cognition, he did not miss any items on the BOS test. So showing that he has good cognitive abilities, but they would, in the future, if he went through for transplant, do a formal neuropsychological testing. For social support, we talked about caregivers during transplant. He had a good support system. His wife would be his primary caregiver, and he had a backup caregiver, which would be his son. His finances and insurance were all in place, and planning on lodging locally during the time of transplant. So that all looked good. And then going to nutrition, his weight was stable. He actually had an increase in weight over the past 4 months of 10 pounds. He states eating 3 meals a day and snacks, and reports no vomiting, nausea, or diarrhea. His diet is high in carbs and sweets. So we talked about incorporating proteins, fruits, and veggies into his diet. And then we did note some biomarkers on his labs. CRP, ferritin, and albumin were all fine. If these labs are abnormal, they usually put the patient at a higher risk for transplant outcomes. So the plan of care for Lenny at this time was that we would defer him only for optimization. So doesn't mean that he will not get the transplant, but we wanted to make some recommendations for him that would increase his chance of doing well with the transplant. We like to have patients at their best right before transplant, because we know that after transplant they're going to decompensate and not be feeling great. So we like to give them the best chance possible. So our recommendations to him were to start an exercise walking program. He needs to walk about 20 to 30 minutes a day outside of his normal routine. And then we wanted to adjust his diet to incorporate proteins, fruits, and vegetables. We did also suggest that he visit the dentist. It looked like he had a tooth in the back that was needed to be pulled, and we like to get all those types of things taken care of prior to transplant. And then we plan to follow his emotional health closely and have him go follow up with pulmonology for any recommendations that they might have prior to transplant. The other thing that needed to happen before we can move forward was that his donor, which would be his brother, needed to be cleared. And then we plan to follow up with Lenny in 3 weeks. And if he has followed up with our recommendations, we would then go through with a transplant. So I leave you with a quote that says, all alone we are smart, but together we are brilliant. So I would just like to say that I really enjoy working in a collaborative effort with the Top Clinic, and I always think collaboration in healthcare is a great thing for the patients. So thank you for listening to my presentation, and please let me know if you have any other questions. I'd be happy to answer about the Top Clinic or myelofibrosis.
Wow.